Evening, everyone. I'm Dr. Ankit Mistry, and on behalf of Intas, it's my pleasure to welcome you all in the 32nd episode of the Endocrine Talk Show series. Today, we will discussing on a landmark clinical trials of the field of the endocrinology that are shaping our future and improving the patient care. Before we beginning, it's my truly honor to introduce our moderator, Dr. Subhankar Chaudhary sir. The Dr. Chaudhary is currently working as a director of the Diabetes and Endocrinology Department at Medica Super Speciality Hospital, Kolkata. With that, now I would like to invite Dr. Subhankar sir to introduce our eminent panel member. Over to you, sir.
Thank you very much. A warm welcome to all our physician colleagues from across the country. It's great to have you sort of enthusing us to go on holding this endocrine talk show. And this evening, as on other occasions, we have an excellent panel to take us through. Can we have there? We have Professor Parminder Singh, who is ex-professor and head department of endocrinology at Dayanand Medical College and Hospital in Ludhiana, who established the first unit of endocrinology and diabetes in the state of Punjab way back in 1997. He is, of course, a very vast experience and has worked as principal investigator in multiple multinational clinical trials and has also published widely. He's currently General Secretary of the RSSDI Punjab chapter. We have Dr. Rana Bhattacharjee, who is Associate Professor in the Department of Endocrinology at the Medical College, Kolkata. He has received numerous awards, including the A.R. Sheth Award from Endocrine Society of India, and he is also publishing prolifically and is also very active as a teacher as well as a researcher. So a warm welcome to you as well, Dr. Rana Bhattacharjee. We have Dr. Srirang Godbole, who is a consultant endocrinology at InStride, Pune, as well as associate professor in the Department of Diabetes at Jahangir Apollo Hospital in Pune. He is a very active person, a wonderful clinician, and was also on the scientific committee of ESICON Pune, which we all fondly remember, which was held in 2011, and organizing committee of ESICON at Nagpur in 2019 as well. And we have a very dynamic young face, Dr. Akhila Bhandarkar. Welcome, Akhila, who is Assistant Professor, Department of Endocrinology and Metabolism at K.S. Hegde Medical Academy at Mangalore. She has had a wonderful academic career, has won numerous awards, including the ESI N. Kochupillai International Travel Award for research in 2025. That's wonderful. I didn't know about this. And first prize for oral presentation in EPICON Delhi State Chapter in 2018. So welcome all our faculty. This evening, what we shall try and do is make the issue of clinical trials a little bit easier for our clinician friends to follow. Now, we do need to make our panelists understand that the target audience are not core endocrinologists, but physicians. So we would like to have not maybe great details about the numbers, those number crunching possibly will not help them, but the most important would be the messages that we can take home. Now, we were just having a chat with Dr. Parminder Singh, and he was pointing out that there could be so many other trials that could have been included. But of course, because of paucity of time, we couldn't include all. And again, we had to sort of fix a date. I thought we'll go by in the last 1 year, roughly, the clinical trials related to diabetes and endocrinology. So let's start off. We all know that these days, the guidelines are all based on results of clinical trials. They dictate the guidelines. And the trials we all know are mostly uh, conducted by pharmaceutical industry. So it's very important that we try and understand how best to look at clinical trials, how to interpret them without needing to go into too much depth of the issue. So can I start with Dr. Rana Bhattacharjee as to uh, the merits and demerits of using clinical trial data for determining how you and I should practice clinical medicine?
Yes, sir. Uh, Clinical trials, particularly randomized clinical trials, very important and considered as a pillar of most of the conditions that we treat uh, and the drugs that we use. So it's considered as one of the highest level of evidence, these RCTs. And there is clear intervention outcome relationship also because those are defined before the starting of trial. So they have to be declared and they actually forms a base, a foundation of various guidelines as well. Another important aspect is that there is a close safety monitoring throughout the trial. The patients are followed up very closely. So those are some pluses, but it's not everything is rosy about them. There are some pitfalls as well. The most important is possibly as the inclusion and exclusion criteria are very strict. So this criteria doesn't fit everyone in the population, the people, those who we treat. So there may be some loss of generalizability, but somehow the samples the researchers they tend to take are more or less uh, kind of representative of the population. And the focus is sometimes as the duration cannot be long because it's a very expensive process. So many a times we have some trials with a hard clinical endpoint, but many a times we have to do with various surrogate endpoints. And as sir was just speaking that sometimes there are some doubt as those are mainly pharma sponsored. However, some step has already been taken in various trials to negate that effect, like a neutral committee which oversee those trials and maintenance of a very strong ethical aspect of these trials, so that that somewhat neutralizes the pharma influence. And so this is all I think about the pros and cons that uh, I can.
Right. Well, one of the issues I think uh, is that the trial has a definite duration, maybe 1 year, 2 years, 3 years, maybe the longest trials would be 5 years. But we use these medications, most of these lifelong. So, do those advantages or disadvantages, do they persist is something possibly we do not know. But as you correctly pointed out, this is possibly the best that we can get, a properly done clinical trial, and then take on from there. And when we talk of clinical trials, we always hear about risk reduction. So active arm with a active treatment and another placebo arm, and then we try to see how better the active arm has done compared to the placebo arm. And we talk of risk reductions. So there are various terminologies: absolute risk reduction, relative risk reduction. Would Dr. Akhila Bhandarkar kindly make it slightly easier for our audience to understand what this all means? Do we need to understand all of that?
Mhm. Sure, sir. Thank you so much for the question. So the terms absolute risk reduction and relative risk reduction, they're kind of, I would say, self-explanatory, although absolute risk reduction makes more sense to us naturally. So basically, I would say absolute risk reduction, it's like a direct difference. So it's like a direct arithmetic difference if you're subtracting two elements. So the two elements here are the two groups. That is, one is the exposed group and we have the unexposed group. So we are seeing the difference in the risk of an event between the exposed group and the unexposed group. Let's say, for example, if you're talking about a vaccine and its adverse outcome, just taking a small number here. So let's say that it has reduced the adverse event outcome from 0.265. I'm taking a number here. So 0.265 to 0.1. So if we straight away subtract these two numbers, 0.265% minus 0.1%. So we are left with 0.165%. So this is how easy it is to know the absolute risk reduction. So we say that here 0.165% means, say for every 100,000 people, the vaccine would prevent 165 adverse events. So it's like a straight, we get a straight answer from that. So it's a direct arithmetic difference between the risk of an event between exposed and the unexposed group. So that's why it actually becomes easier for patients to make a informed decision if they want to choose a particular drug or choose a particular therapy. So absolute risk reduction makes it easier for people to understand the actual importance or significance of that drug or anything else. So whereas relative risk reduction, basically it's a ratio. So it's the ratio of, say, risk of an event in exposed compared to the unexposed. So it's not a direct difference. So it's basically a ratio. So this usually, the percentage or the number we get out of this, it's a little bigger. So sometimes it can sound alarming actually. Coming to the same, so say adverse outcome of COVID-19 vaccine. So in fact, this happened with one of the COVID-19 vaccines. So where the vaccine was shown to have, say, a relative risk of 2.65 relative risk for occurrence of blood clots. But when it was actually compared to the the absolute risk was compared to the relative risk, the number was found to be pretty less. So because it depends upon the actual prevalence of the event in the group. So and that kind of gave the green signal for the vaccine, and it was used. So that's how we know that absolute risk reduction kind of becomes much more important compared to the relative risk reduction. Although in some of the scenarios, I think taking both of them together will definitely make more sense.
It works the other way as well. Uh, for example, here you talked of adverse event, but when you talk of efficacy,
Efficacy, yes.
when you look at the relative risk reduction, it's 30, 40, 50%, whereas the absolute risk reduction may be minuscule. And
Yes.
the pharma industry will, of course, come and show you there is a 60% reduction.
Yes.
So that's somewhere, I mean, we need to
Yes.
possibly be a little bit conscious about what exactly it's meant, of course. Relative to placebo, there is a bigger risk reduction, but the absolute risk reduction may not always be huge. Now, while on the same issue, can we come to Dr. Srirang? So we again sometimes get to read about number needed to treat, NNT. So what does it mean, and how do we interpret that?
So basically, the takeaways from a clinical
So
trial.
we are sort of preparing the ground before we launch into the clinical trials. So yes, Dr.
That's right.
Shiran.
So basically, any clinical trials, the takeaway from the clinical trial needs to be readily, understood by the clinician. So number needed to treat, or NNT as it is called, it indicates how many patients need to be treated with a specific intervention to prevent one additional negative outcome or to achieve one additional positive outcome when compared to a control group. Now, so it's probably easy to understand how many patients really need to treat, let us say, to prevent a particular symptom or death, or let's say some disease, or to prevent a relapse. So the outcome could be different. And it's actually pretty simple to calculate the NNT. If you have understood what Dr. Akila told us about absolute risk reduction, you take just the reciprocal of the absolute risk reduction and get the NNT. So it's as simple as that. So for example, let me give you an example. Let us say a drug is reducing the risk of heart attacks from 20% to 10%. The absolute risk reduction, as Dr. Akila pointed out, would be 20 minus 10, which is 10. That's a percentage. You now convert it into a decimal. So that becomes 0.1. And now the reciprocal of 0.1 is 1 upon 0.1, which is 10. So which means the NNT is now 10. So you would need to treat 10 patients with this particular drug to prevent one additional heart attack. Now, this is very important for the clinician to really understand the practical impact of a specific intervention. It's also easy to communicate this number to the patient to help them to understand how a given treatment that you are planning would probably help them. But it also helps insurers, because those who have to allocate resources need to know whether it's worth spending, how much they need to spend on a particular drug if it's going to prevent a certain negative event. And obviously, you can also have number needed to harm. You have number needed to treat, but you can also have a number needed to harm, which will actually tell us the assessment of the risk. So this is essentially a measure to help us understand the impact of an intervention readily and easily.
Right. So if I've understood you correctly, so if you are looking at number needed to treat, the lower the figure, the better. Means
Yes.
less people need to be treated to
Yes.
achieve
Yes.
an outcome.
Yes.
And for the number needed to harm, the higher it is, the better.
That's right. That's right.
Right. Okay. Good. So now we come to the wisdom of Dr. Parminder Singh. So we all talk about MASLD these days, another epidemic, endemic, whatever we may call it. And we have been treating it in different ways, but US FDA, in its wisdom, had the first drug approved by the name of resmetirom, which is a thyroid hormone receptor beta receptor agonist. So again, it's in the realm of endocrinologists to talk about resmetirom as much as, or maybe more than, gastroenterologists, I would feel. So can you sort of quickly take us through or tell us as to what does the clinical trial based on which US FDA approved this drug, what does it tell us? How effective is this in terms of treatment of MSLD? And I would also quickly like you to size it up to saroglitazar, which we have been having in our country. Our CDSCO has approved it, and we have had some experience with it. So how does it compare? I mean, looking at the trial results.
So very good evening to all of you. And thank you, Dr. Shabankar, for organizing such a, platform and discussing the clinical trials. It is very good initiative. In fact, I will say this is the first program I liked it so much. We are going for lectures everywhere and doing all these meetings, but this was excellent format. So going to first to the Maestro NASH trial, which is
sorry, Dr. Singh. Let me once again appeal to all our participants, our viewers, to please kindly put in your questions, and we will try and answer as many of them as possible. You won't get such a galaxy of endocrinologists every other day. So please put in your questions so that we can have them your queries resolved. Yes, Dr. Singh. Sorry to have interrupted you.
It was a phase 3 randomized 52 weeks controlled trial. So it was done in biopsy proven cases of NASH with fibrosis. In fact, they have taken fibrosis stage F2, F3, and very little one, about 1 to 5% of F1's B stage. So from that angle, it was a NASH proven, biopsy proven case. So that's the plus point of this clinical trial. And given a doses of 80 and
sorry to interrupt. So is this not a negative point also, that so I can use the drug only if it's biopsy proven, otherwise can I use it?
I will tell you 2 points further. Right?
Okay.
So as you have already pointed out, that is a thyroid hormone receptor beta agonist drug, which is a liver specific drug. So what this trial has shown over a period of 52 weeks, that there is a NASH resolution with no worsening of fibrosis in as many as 25 to 30% of the patients. All right, that's number one. And second point is fibrosis improvement occurred in almost, again, 25% of the individuals who took this drug. So other parameter also improved. Now, as endocrinologists, we are always concerned that this is a thyroid hormone receptor agonist, so it may have a diverse effect on the heart, on bone. It was not seen. So it is free from those arrhythmias and all those side effects effect on the bone, like osteoporosis. So there is no weight change, right? So this is what. Now, plus point of this study was that this study has other parameters also, like they have done the elastography also, liver stiffness, they have taken all those parameters. So in future trials, probably, and they have validated that also with liver biopsy also. They have compared these two parameters, and they found that the parameter, non-invasive parameter, they are also valid. But of course, you need more data for that. And limitation of this study was what I found is that we have improvement in the liver biopsy, but we don't have the clinical outcome data. Clinical outcome data that future cirrhotic risk or hepatocellular carcinoma risk, or for that matter, other metabolic parameters, ASCVD, all those things. But this was a 52 weeks trial. Probably we require more time with this drug to know whether this is beneficial in that aspect also. The positive point I have told, as I have told, this is that non-invasive testing also gets a flip in this trial, probably with more trials, right? More such parameters will come, then we may not need biopsy as such, liver biopsy. Now, coming back to saroglitazar, which is a Indian drug, we have phase 2 trials with the saroglitazar, and DCGA has given it go ahead for NASH also, but we don't have a phase 3 clinical trials biopsy proven. It's ongoing, I think so. So that's why it didn't get any approval from FDA. FDA has mandated that it has to be a biopsy proven data, which should be the hallmark of any drug for NAFLD or for that matter NASH.
Right. Yeah. And if I may add, also encouraging pointers have been improvement in the lipids. LDL cholesterol was lowered, and we all know that uh, the biggest cause for mortality in people with MASLD is not a liver failure, but a cardiovascular event. So that sounds encouraging. And also, I understand that the study is ongoing so as to give at least the liver specific, the details that you wanted to have. Possibly we will get in whatever the next 1 or 2 years. Right. So we continue with MASLD for now. And I'll turn to Dr. Rana Bhattacharjee. Resmetirom has now possibly just begun to be available to our patients on a named patient basis on compassionate grounds, but still it's not widely available. But something that's been available to us for quite some time are the gliflozins. And especially there was a study within the last 1 year showing some effect of dapagliflozin in this condition. So would you quickly try and summarize if we can provide the advantage of dapagliflozin to our patients?
Sir, there is a study from China. It's called DIN. So this particular trial actually looked at biopsy-proven MAC patients. They followed them up, and their primary endpoint was improvement of NASH or MASH, whatever, without worsening of fibrosis. So that was the primary outcome. So they looked mainly into the improvement of MASH. However, there's one secondary outcome was there, that there was whether there was some improvement of fibrosis as well. So they tested that, and in dapagliflozin, there are some encouraging signals. I won't go into detail of with the numbers and all, but in comparison to placebo, there is improvement of in the primary outcome measures, and also secondary outcomes, that is prevention of progression of fibrosis and some reversal, although as it is a secondary outcome, it's more of a hypothesis generating, needing further confirmation. So there is
yeah,
sorry.
please, please continue.
So possibly there is no proof of reversal of fibrosis as of yet as a primary outcome with this dapagliflozin. However, the progression of fibrosis is prevented and there was reversal of MASH. So that's
so that sounds encouraging. So what sort of comparable data have we got for empagliflozin?
The empagliflozin, sir, I have yet to come across similar
Such a
trials.
definitive
There are some
study.
secondary.
Okay. Yeah.
So there is no dedicated study as far as I remember, sir.
Right. Yeah. Okay. So we're talking of saroglitazar, which is a dual PPAR, predominantly an alpha and also a PPAR gamma agonist. So there are also studies with a pan PPAR agonist, lanfibranor. So can I ask Dr. Akhila, is there some prospect for lanfibranor? Will it do better than just a PPAR alpha and gamma agonist?
Yes, sir. So the PPAR agonists, as of now, what we have, as you rightly pointed out, that's the saroglitazar. So this has an additional receptor that is basically the delta, but it's a beta delta kind of a combination. So that's rightly why it's called as a pan PPAR agonist. So this particular receptor has basically effect on fatty acid metabolism, and that's the reason I think we can kind of consider this as an added advantage over the already existing saroglitazar. So since the alpha and gamma has already been taken care, and this kind of has a well balanced effect on all three receptors, so that's why a kind of a pan effect. So this particular trial, Symphony trial, so that was the one which studied lanfibranor. There are other trials as well, but this is the one which is kind of a major one. And this had both the doses of 800 and 1200 mg. But I think 1200 mg dose, which was like once daily, that was the one which made a better impact. So it was a treatment trial of about 24 weeks, like 6-month trial. And the primary endpoint was like a decrease in at least 2 point in the SAFA score. SAFA score was used to measure the disease activity in that case. So without worsening fibrosis, that being the key. So it had to reduce at least 2 points in the SAFA score without actually worsening the fibrosis. And with this drug, almost 55% of patients had achieved this primary endpoint. So with 800 mg, some 48 to 50%, I think 48% to be precise. And with 1200 mg, 55% of patients had achieved the primary endpoint. So compared to placebo, it was mainly the 1200 mg that made a significant difference. And the study also had the secondary endpoints like resolution of NASH without worsening of fibrosis and improvement in the fibrosis stage by at least one. So both of like not both the endpoints were achieved in secondary, but it's a primary endpoint which was completely achieved. So that's why I think this is kind of a promising drug to be here. And added to this, the side effects was also not major. Just very few patients had, like, even the dropout rate was just less than 5%, and very mild side effects like diarrhea, nausea, some edema, anemia, nothing very specific. So it was kind of similar compared to placebo, and liver enzyme levels were also not worsened. So it had, in fact, improved. So that part was also taken care. So I think
Right.
it's a promising drug.
So there's some promise there as well. Can I ask quickly, Rana, though this is not part of a clinical trial that has come out in the last 1 year, what about our dear old pioglitazone? Please unmute yourself.
Yes, sir. Yes, sir. Pioglitazone has also been tried and successfully. However, the dose that is needed for prevention of fibrosis is on a higher side than we usually use for diabetes nowadays. So the standard dose is 45 milligrams. We do not know whether with the standard dose that we use there will be benefit or not. So definitely pioglitazone has some advantage in this particular aspect.
Right. And we have a difficult question for Dr. Parminder Singh from Dr. Rajdi. So the question is, resmetirom, does it have any significant effect on hypogonadism? I'm actually not aware, so maybe Dr. Parminder can make us wise. But of course, what the suggested mechanism is through increasing SHBG. I don't think
Yes.
SHBG increase will cause hypogonadism per se. Yeah, but it's your question, Dr. Parminder.
No, SHBG does increase, and that is in fact that's a marker of can I say that whether the person will improve with resmetirom therapy or not. SHBG is a marker. So as we know in clinical endocrinology, if the binding proteins becomes high in concentration, the free hormone remains the almost the same. Body compensate for that. So there's no as such nothing like that effect that person will turn hypogonad, nothing of that. But good question, and answer is no effect.
Yeah, thank you, Dr. Rajdi, for that interesting question. So now we talked about the SGLT2 inhibitors. Can I ask Dr. Srirang Godbole as to GLP-1 analogs or maybe mono analog, dual analog, what is their effect in MASLD? In fact, recently US FDA has now approved beyond risperidone, the second drug is semaglutide for MSLD. So what's the status of these?
So another exciting approach to treat MASLD is obviously either a single agonist like a GLP-1 receptor agonist, or maybe a dual agonist, which includes a GIP agonism as well, or maybe a GLP-1 RA plus a glucagon agonist like pemvidutide, or a triple agonist which has GLP, GIP, and glucagon like retrotrudide. And even in the days of good old liraglutide, it had a lean trial which studied NASH, as it was called at that time. It was a phase 2 trial. And subsequently, as I mentioned, the pemvidutide also has undergone a phase 2 trial. But these trials that looked only at the liver fat content, not at NASH per se. You also had a trial, the retro trial with retrotrudide, which is a triple agonist, which was again a phase 2 trial looking at the liver fat content. With tirzepatide, again, you have a phase 2 trial called Synergy NASH, which actually looks at biopsy-proven MASH, and that showed great promise, which is why tirzepatide now has the BELIEVE trial, which is going on in non-cirrhotic MASH, looking for resolution of steatohepatitis and also other secondary endpoints. And after going, as you mentioned, semaglutide went through a big phase of phase 2 trials, and then subsequently the interim analysis of the Essence trial was published in late April this year. And this essentially is still an ongoing trial involving, I believe, 1,179 patients with biopsy-proven MASH with stage 2, stage 3 fibrosis. And this is planned for 240 weeks. But the interim analysis for the first 800 patients was published, as I said, in April this year. And there were two co-primary endpoints. One was the resolution of steatohepatitis without worsening of fibrosis. And secondly, the reduction in fibrosis without worsening of steatohepatitis, with, of course, various other secondary endpoints. And clearly, this was with 2.4 milligrams once a week subcutaneous semaglutide, or Wegovy as it is called. And it clearly showed benefit for the co-primary endpoints. Resolution of steatohepatitis was the tune of 64% approximately, compared to some 36% or so for the placebo. Similar figures like 36% for the reduction in fibrosis in the semaglutide arm versus, let's say, 22% in the placebo arm. And as a result of this interim analysis, Wegovy, as you rightly mentioned, or semaglutide, has got a US label. It's not yet applicable to India, but a US label that it is now indicated for non-cirrhotic MASH with stage 2, stage 3 fibrosis. That's the US label, which was added to 2.4 milligram semaglutide very recently.
Yeah, thank you for showing us newer avenues. So, yes, Dr. Parminder, yes.
I have, Shubhaka, I have one point that these drugs like GLP-1 receptor agonist, they causes weight loss also. And that mean in particular, that can little bit alleviate the problem of fatty liver disease also. That's one. About the rest matter on that one point I have found that there's no weight loss and such. Still, it's producing the result. So that was
Right.
a good point from that account.
Right. Good.
That's
Good.
probably because there are probably some, maybe some GLP receptors, GLP-1 receptors in the liver. So that also maybe most of it is weight related, of course, but maybe part of it
Yeah.
is not related to
Yeah.
weight.
Yeah. Right. Uh, can can I just be the devil's advocate, Dr. Shriyang, and ask you that you said semaglutide causes, let's say, 40% reduction, whatever. Placebo causes 20% reduction. So I'm a poor person. I can't afford semaglutide. So I'll go for the placebo. That will also give me 20%. That's also, for some trials, 20% reduction is shown.
So I believe it's the p-value that's important. You have to have a statistical
Okay.
significance compared to
Okay.
a control arm, and people in the
Okay.
real world are not in controlled situations, so they can easily
Okay.
default. These are highly
Right.
controlled
Yeah. So,
situations, and RCT
anyway.
has a highly controlled situation.
Okay. Right. And another question we have in our chat box, Dr. Surinder. So nausea, eruption, loose motions, side effects of GLP-1 analogs. Is it a sign of dose effectively, or maybe does it mean there's the drug? If the drug works, then you'll have those side effects. I don't know exactly what our participant means.
Well, one of the effects of a GLP-1 receptor agonist is delay in the gastric emptying. And there's, of course, early satiety. So both of these together may lead to that feeling of fullness of the stomach. And if the person is eating in a hurry, that feeling of fullness can easily translate into nausea and can progress to vomiting, especially if the food is oily. So usually these things need counseling. They also need a gradual initiation of the dose and a gradual escalation of the dose. And one may go slower than the recommended escalatory, stages in a given patient. And you can even de-escalate as is, recommended. If 2.4 is not tolerable to the patient of semaglutide, you can, down-regulate to 1.7 milligram and so on. So make the patient comfortable, and only then you should go for the higher or the recommended dose. But of course, if you have diarrhea, I really don't know if there's any solution to diarrhea. You simply have to stop the drug. But for nausea, usually if the patient is patient, you have counseled, many of these patients overcome that effect over a period of time. These are usually transient effects.
Yes. Maybe diarrhea could also subside. I mean, I don't know. Right. So we have got some other questions. Yes. So let's talk about tirzepatide, because we have in our country now tirzepatide is also available. And it's come up very strongly as an anti-obesity drug, and it's competing with bariatric surgery as something that can cause significant weight loss. So can Dr. Parminder Singh sort of give us a quick look at whatever the recent trial on non-diabetic people with obesity, how tirzepatide works, or how effective is it?
So thank you for your question. This trial is Surmount trial, which was published in NEJM. And again, it was a terazepatide study over a period of 72 weeks, right? And phase 3, of course, and involving 2,500 patients approximately with mean BMI of 38, right? And what three doses were given: 5 milligram, 10 milligram, and 15 milligram, compared with placebo. In fact, reduced the weight very significantly. In fact, I have become from that trial become a fan of this compound as such. And there are plenty of obese people. They were just trying all those things. This has come as a good respite for all of them. And in fact, weight loss was very significant, around 15%, 19%, and 21% with 5, 10, and 15 milligram doses over a period of 52 weeks. So very impressive effect. Along with that, blood pressure, systolic and diastolic, decreased by 7 and 4 millimeter of mercury. Then LDL came down, free fatty acid came down, insulin level came down. So all other, cardiovascular endpoints or risk factors, they also came down quite sharply, quite good also for the patient. In fact, more than 20% weight is also recorded in almost, you can put it in 50% of the individuals. So very good from that angle. GI side effect, almost 6 to 8% have so severe side effect, they have to discontinue the other agent. But otherwise, it's a good trial to say that terazepatide can reduce weight to the amount of roughly, I put it 15 to 20%.
So today we really have very effective agents which will work medically to reduce body weight. But a very important question that every patient at least asks me, I don't know what they do in Ludhiana. Uh, डॉक्टर ये दवाई कितने दिन के लिए लेना है? So
Yeah.
what we tell them? 2 months, 3 months?
It's a question which every patient generally asks. So, although the pharmaceutical and other things, and we also know as endocrinologists, we know that obesity is a chronic disease. So, first we have to explain the patient it's a chronic disease. It's not going to go away. Then they will certainly say, "Sir, ये इतना टाइम ही चलनी है, फिर इतना महंगा दवाई किस लिए? बात तो वही है बाद में." And they do ask this question also that once I leave it, okay, I have taken it for 1 year, what happens if I leave it? Because most of these people have tried many methods, diet, exercise, and going to, diet specialist also for the same job. And they'll say, sir, what will happen if I leave it after 1 year I've lost? So you have to tell them probably it's a chronic disease. You have to take it as long as you are obese, although we say that it's like an antihypertensive medication. So you are
Right.
hypertensive, take it for long. But certainly, this probably answer will be, we can give very emphatically when the cost is very less, and then you can say, okay, you can continue taking it.
Right. We have a very interesting and intelligent question by Dr. Vishal, and maybe Dr. Parminder, you take it. So he refers to the Surmount OSA trial, which showed that tirzepatide led to about 20% weight loss and improved sleep apnea almost as effectively as CPAP. So how do you see this reshaping the management of sleep apnea in obese patients? Thank
Yes,
you, Dr. Vishal, for this question.
yes, I agree with Dr. Vishal's question, and the answer lies in that weight reduction certainly improves OSA. We all know that you give a trial of anything when we tell our patient reduce your even bariatric patient, you know, BMI more than 40. Once he undergoes bariatric procedure, OSA generally goes off like anything. So it's a weight related kind of thing. So weight reduction generally improves OSA, and many patients will be off CPAP if they lose 15 to 20% of the weight, almost equivalent
Right,
to the diabetes remission, 15% there, 15% formation of OSA also.
right. Thank you. So when we look at these trials with GLP-1 or GLP-GIP analog, we do see that there is a difference in the amount of weight loss achieved in non-diabetic versus diabetic. So can I ask Dr. Rana Bhattacharjee, and it does appear that diabetics tend to lose less weight than non-diabetics. Is there any explanation for this?
Difficult questions. Basically, all the trials that have been done, I mean, with whatever either GLP-1 or even dual agonist, this is something that has been seen quite consistently. So the weight loss that is achieved on an average by these agents are around 30 to 50% less than that achieved in uh, individuals without diabetes. So possibly, sir, there are some explanations, although the exact mechanism is yet to be proven. So possibly the concomitant medications that we use in diabetes, like insulin, sulfonylureas, pioglitazone, they can cause weight gain, which may counter some of this effect. On the other hand, if a patient has uncontrolled diabetes to begin with, and with whatever drug we control, there is a component of weight gain because of less glycosuria, so more energy
Okay.
conservation. So possibly this is another explanation. Sometimes these drugs are very potent drugs, which for hyperglycemia as well. So in fear of hypoglycemia, like other drugs, possibly some individuals seeing their numbers becoming so low may tend to overeat. The exact cause is not known, but possibly some one or many of those factors may be responsible for this effect.
Right.
So,
So
so,
we
so
mean,
if I can just
yes,
interject,
yes,
one possible reason, I mean, there could be several reasons, and we don't know all of them. But one possible reason is people in a diabetes trial with these agents are probably more geared towards their glucose control rather than their weight control. Whereas
okay,
those who are in an obesity trial who do not have diabetes are more motivated towards weight loss. That is possibly one explanation. And the other thing I must
yeah,
also, in addition to this, women do better for weight loss compared to men. It's consistently
yeah,
seen.
yeah, yeah,
That is also something we need to keep in mind. So maybe
Hmm.
a male diabetic patient may not lose that sort of weight, which is advertised or which is, maybe seen in the clinical trials, maybe.
right. So whether we understand exactly the reason or not, I think we need to keep in mind for our all our physician colleagues that when we talk of this significant weight loss of 20%, maybe with tirzepatide, this possibly will not apply if we are using this for our patients who have also got diabetes. So we need to keep this reality in mind. Now, we talked about tirzepatide. It appeared that the weight loss ability is higher with this than with pure GLP-1 agonist. And we thought it's because of GIP agonism being added to the GLP-1 agonism. But I find, of course, endocrinology, medicine, everything, endocrinology in particular is especially complicated. So, can I ask our young uh, participant, the means faculty, Dr. Akila, are we sure that GLP plus GIP agonism is good or GLP plus GIP antagonism is good? Because we have got some compounds which are sort of an antibody peptide conjugate, which at the same time cause GLP-1 agonism but cause GIP antagonism and have also shown pretty good results in terms of whatever we look at HbA1c lowering and all that. So can you quickly tell us about it?
Yes, sir. Thanks for the question. So, as it sounds, I think it's definitely sounding very contradictory that when we are having a tirzepatide, which has a, say, GIP agonistic drug, how can something with a GIP antagonism also be beneficial? So, I think the debate has to continue because both the approaches have been like showing benefits, at least this one in the trial. So we already know that the tirzepatide has one of the components as a GIP agonist, but then there is a small possibility that has been raised that the prolonged, say, GIP agonism in tirzepatide also may gradually lead to desensitization of the receptors, and maybe over a long time, the drug is actually acting like an antagonist because of the receptor desensitization. So, but despite that, we do see benefits with the tirzepatide, even with the continued usage. So, similarly, the drug, what Sir was just mentioning, that's GIP receptor antagonist antibody, which is actually conjugated with the GLP-1 receptor peptide. So that's called maritide. So that's the conjugated molecule. So it is quite new, or it's a novel molecule, even when compared to tirzepatide. In that sense, it's once monthly, injectable. So now we were so excited that we didn't have to take something daily. Now once weekly had come, and now this one in the pipeline is once monthly. And the doses, although mentioned in the trial, is a little bigger, like 420 mg. And in the trial, once monthly doses were given, and in one of the arms, actually after 3 doses, and after 3 doses it was discontinued, and even then for the remaining 2 months, that's nearly 60 days after discontinuation, also the weight loss achieved was actually maintained. and a very small percentage continued to lose, but majority at least maintained that even after discontinuation. So I think this would be one of the hopes we have compared to the existing drug. Maybe the benefit would remain. We don't know for how long when done in further trials. And another important difference is that the difference in diabetic and non-diabetic, as Dr. Rana sir has just mentioned. So that difference was also there in this trial, in the sense 20% weight loss was seen in non-diabetic obese subjects, but even in those with the diabetes, nearly 17% weight loss was seen. So I would say the difference at least is not too much, like 20% and 17% compared to the other trials where nearly 30 to 50% less weight loss was seen. So I think that's another arena where this drug might have an upper hand. And even with the continued usage, say beyond 52 weeks, there was no plateauing. So there was a consistent weight loss that was going on. And added benefits which is seen with the tirzepatide, that's the cardiometabolic risk reduction, say the weight loss along with the weight loss. So that was also seen. So I think this is something definitely to look forward to.
Right. So probably we still have not understood our physiology perfectly. I mean, GLP and GIP, we are still learning. And so there's a quick question, maybe Dr. Srirang. Dr. Harvind wants to know whether GLP-1 agonists increase CVA and deafness.
Sorry, I didn't get the question. Sorry.
Uh,
One second.
increase
One second.
CVA. Yes.
Just a minute. Just a minute. Sorry, there was a disturbance. Yeah. What's the question really?
The question is whether GLP-1 agonists increase the risk of CVA or deafness. That's a question from Dr. Harvind.
CVA is, no, I've not come across
No,
this sort of data. If it is there, I'm not aware
no.
of such data.
And neither about deafness. Would anyone like
Sir,
to comment?
sir, there are some reports of vestibular dysfunction. And in fact, one of my patients developed he also had a history of this many years, but somehow after introduction, he developed. So that is described, but I'm not sure about the deafness part.
Okay. About the vestibular dysfunction, I wasn't aware. Okay, thank you. So, Dr. Srirang, so we do understand there are so many trials, so many drugs available, but we are fortunate that in our country right now, we have available semaglutide oral, semaglutide injectable tirzepatide. We even have got liraglutide injectable, and which is also at a lower price because it's now become branded generic. So where do you put each drug? Can we do that?
We must first realize that liraglutide and oral semaglutide in India have a label for type 2 diabetes. They do not have a label for obesity per se, if you go strictly by the label. Whereas injectable semaglutide 2.4 milligrams as well as tirzepatide are approved in India both for type 2 diabetes as well as people with overweight and obesity who have got established cardiovascular disease. So there is a difference in the label which we must understand. As far as oral and injectable semaglutide are concerned, there is no head-to-head comparison between the two. And 1 milligram of injectable semaglutide is supposed to be equivalent to 14 milligrams of oral semaglutide. There are indirect comparisons between the two, which have largely shown that the HbA1c reduction and the weight reduction is comparable. And in fact, surprisingly, GI side effects were found to be in this indirect comparison less common with the oral semaglutide compared with the injectable semaglutide. Again, there is no head-to-head comparison between tirzepatide and oral semaglutide. The comparisons head-to-head that we have are with injectable 2.4 milligram semaglutide versus tirzepatide, as is the SURMOUNT-5 trial. And you also have the comparison of tirzepatide with 1 milligram of semaglutide in the SURPASS-2 trial for diabetes. So if you consider these two trials, the SURPASS-2 trial was a diabetes trial comparing different doses of tirzepatide 5, 10, and 15 milligram with 1 milligram of semaglutide in around 1,879 type 2 diabetic patients. This trial went on for about 40 weeks, and the primary endpoint being the HbA1c reduction. And semaglutide gave a 1.86 HbA1c reduction, but the smallest dose of tirzepatide, 5 milligram, gave a higher statistically significant HbA1c reduction compared to 1 milligram. So 5 milligram of tirzepatide gave, I think it was 2% A1C reduction compared to 1.86 with the semaglutide, with the higher doses doing even better. So in terms of A1C reduction and even weight reduction in that particular trial, even the smallest dose of tirzepatide was superior
So,
to.
Dr. Srirang, so what we understand is then, therefore, we don't have a need for semaglutide. Tirzepatide is a better thing if the patient can afford it.
So if you want to go strictly by A1C reduction, you want to go strictly by obesity, yes, tirzepatide in both the trials, the SURMOUNT-5 trial and the SURPASS-2 trial, beat injectable semaglutide, 1 milligram, 2.4 milligram respectively. But
Hmm?
injectable semaglutide was introduced a little earlier, and tirzepatide is hot on its heels. And therefore, semaglutide has got this label for MASH, which tirzepatide is
Yeah,
lacking. And the CV outcome trial of injectable semaglutide is published. Only the top line results of tirzepatide, the SURMOUNT CVOT, have been published. But I'm sure it's just a matter of time before those trials also get published, and then we'll know the results. But these
right,
additional labels, it's only semaglutide which has, and tirzepatide does not have.
right, wonderful. So, we will come back to Dr. Parminder Singh. So, we have with us oral semaglutide, which is a peptide which can still be absorbed with various techniques, addition of a snack. So now we know of small molecule GLP-1 agonism, and there's a particular drug called orforglipron. So would Dr. Parminder Singh tell us how does it compare to oral semaglutide? This is also oral. This is also oral GLP-1 agonist. So how does it matter? Which one?
So orforglipron is a non-peptide, as told by you. This is a GLP-1 receptor agonist again, and it has undergone phase 3 trial. And in a patient who are on, freshly diagnosed diabetes with diet and exercise, this drug was given, and in various doses like 3, 12, and 36 milligram doses. And what we have found is that it causes a reduction in HbA1c to the tune of 1.4% in HbA1c reduction. And weight loss significant, almost you can put it 4.56% and 7.6% in 3 doses as such. So significant effect on the weight. That was in this clinical trial, which we have achieved one trial. They have shown that there is a reduction in the HbA1c 1.4, and there is a second primary endpoint was weight. Weight was also reduced to the tune of 5 to 6%. Now, comparing it with oral semaglutide, almost similar efficacy as far as uh, effect on the HbA1c reduction, but this drug is more, it's a more favorable result on the weight, because in Pioneer trial we have only 3 to 4% weight loss. Weight loss is little higher in this trial, but it's not that high, but it was little high. The good point about this molecule is it's a non-peptide. So precaution as such, which were there with the old semaglutide, probably these things are not there. But it is too early to say that this is a very good molecule. It has only one trial, that too early in the disease of diabetes. So it is too
Right.
early to say that this is very good vis-a-vis oral semaglutide.
And can we expect that GI side effects will be any less?
Almost same with this one.
Yeah,
Almost
would
same when you
right,
compare it with the even injectable oral and this orforglipron.
right,
Almost same, similar side effects are there.
right. Right. So we have a question from Dr. Satyajit. So do you suggest blood sugar monitoring in non-diabetic obese individuals who have been put on tirzepatide or maybe even semaglutide or whatever? Anyone quickly? Yes, Rana?
Actually, we do monitor blood glucose level in any patients with obesity. So same hold true for this. So
So
for
I
development,
suppose I suppose the imputation is with the risk of hypoglycemia.
no,
Is what,
it's
of
not
course.
documented. So hypertension is not documented.
Right. Okay. Okay. So maybe we are coming towards the end of our session, and it's been interesting so far. So can I ask, continue with Dr. Rana and ask about any promise for type 1 diabetes? Is there a cure on the horizon with stem cell and all that?
Yes, so there are many approaches and pancreatic replacement, beta cell replacement, and one of the approach is stem cell replacement. So a recent trial, Jimmy Slell, which actually showed that some benefit with this agent. There is a remission in a relatively high number of patients. Although this is a phase 1 and 2 trial with a very short duration, as far as I remember, it's around 1 year, 365 days. But there is a significant improvement. Like out of 14, 12 patients completed the trial, and around 10 had, I mean, they didn't need insulin any further beyond 1 year. So that's quite encouraging. And even the rest, the other two, with them also the A1C level was less than 7 without any increased risk of hypoglycemia. So that is quite encouraging result, but sir, it's very
But of course,
early
it's
and
too early.
365 days
Right.
is too early to say.
Right.
Uh,
So I'll ask Dr. Akhila. So acromegaly is a condition which is rare condition. Maybe most physicians are not involved in its management, but it will be good to know any advances that are taking place in its treatment. Primary treatment is surgical removal of the tumor, the growth hormone secreting tumor in the pituitary gland, but adjunctive treatment with medicines, with radiotherapy is often needed. And we have traditionally used somatostatin receptor analogs, which are injectable, octreotide, lanreotide, and all that. So today we now know that there can be oral uh, oral octreotide also, but beyond that, specific molecule like paltusotine. So, do you think there is a scope for oral agents taking over the place of this injectable somatostatin receptor analogs?
Sir, thank you for the question. So I think the last part, will the oral, the paltusotine or the oral octreotide capsule, will it take over or will it replace the existing injection? So I think that's how it goes. So this is, it has stood the test of time, the injectable octreotide and lanreotide. And rightly so, even in the trial of paltusotine, which is once daily oral octreotide capsule, so that was actually given in those patients who were already on injectable octreotide and lanreotide and who were well maintained on that. So in this study, that's the Maverick trial, it found a good result also. That's those who were already on those medication, and when it was replaced by the oral paltusotine, they did well and they did maintain or achieve the target. That's the IGF-1 less than 1.3 times the upper limit, and the growth hormone less than 2.5 microgram per liter. So they did achieve that, and even up to 3 years follow-up did show a durable result. So it was a kind of maintain, but still it wouldn't replace the existing injectables, I think, for a long time to come.
Right. Okay. And maybe we'll try and wind up with maybe a question each to Dr. Sriram about GnRH antagonists. We endocrinologists more often use GnRH analogs, but GnRH antagonists have been there for some time, but they've been in clinical use also in recent times, especially by our gynecology and uro-oncology colleagues. And the advantage of them, again, is that they are oral. So would you like to comment on recent evidences with the use of these agents?
So there are There are two sort of oral GnRH antagonists which have undergone trials and some have even received approval. One is called as relugolix, which is a tablet. It's a GnRH antagonist, largely used in and approved because of its efficacy in a clinical trial called SPIRIT trial. So these trials involved premenopausal women who had moderate to severe pain. They had endometriosis, and relugolix was given with a combination of 1 milligram ethinyl estradiol plus zero point 0.5 milligram of norethindrone acetate to alleviate the vasomotor symptoms that you would get with a plain sort of a GnRH antagonist. And these trials were continued for about 24 weeks. There are also extension trials which went on for 2 years. And clearly, there is a significant reduction not only in the menstrual pain, but also in the pelvic pain in between the periods. So this is one application of relugolix. But our oncology friends also would use it in prostate cancer because relugolix has been found to cause almost a 90% reduction in testosterone levels, like near castration levels in CA prostate. So that is one more indication. And also another a drug called elagolix is used in uterine fibroids. That's again a GnRH antagonist, and it underwent a trial called the UF Extend on a UF trial. That is the uterine fibroid trials where there's a regression of uterine fibroids and reduction in pain. So a lot of application of GnRH antagonists by gynecology and the field of oncology.
Right, good. So maybe we have the last sort of question from our side, and this is to Dr. Akhila. We know Cushing syndrome is a difficult condition to diagnose and especially to treat. And there have been various drugs that have been used. And more recently, there has been a study with one more glucocorticoid receptor modulator, let us say. We already have mifepristone there, so there's a new one called what's it called? Relacorilant.
Yes.
So what is there a scope for this drug to be used in future?
Yes, thank you for the question. So, as you had mentioned, sir, it's about mifepristone being already there, and how is this different, and does it have a space? So, it's basically it has a similar mechanism of action, I would say, in that it's a highly selective glucocorticoid receptor modulator, but it's not structurally similar to mifepristone. And that being the reason, it doesn't really have the unwanted action or the side effects of mifepristone, like blocking the progesterone receptor or other androgen receptors and all. So the unwanted side effect of vaginal bleeding, all those things are not there with the relacorilant. And not just not having the adverse events like mifepristone, but it is even better because it doesn't have much of a hypokalemia and not even much of adrenal insufficiency or QT prolongation. Plus, even the trial patients basically included patients with hypertension, diabetes, and all. So it was seen to benefit hypertension significantly, even diabetes, HbA1c reduced significantly with the reduction in the the control of the cortisol action mechanism of action, basically. So even when the body composition analysis was done, it was found to kind of reduce the weight, but it was mostly the fat, and the lean mass was seen to be still maybe it was maintained or it was improved also in some patients. So that way I think it definitely has some benefits over mifepristone, but much of studies awaited actually for it to come to the market.
Right. So we had a wonderful year actually going behind us with wonderful new trials coming in and giving us new molecules, new indications for use of even old molecules. And it's exciting days and in the field of metabolic disorders, obesity, especially diabetes, and also MSLD. And beyond that, in core endocrinology, also there are important developments that are taking place. We had a wonderful discussion thanks to our panelists, Dr. Parminder Singh, Dr. Rana Bhattacharjee, Dr. Srirang Godbole, Dr. Akila Bandarkar. And of course, thanks to all our audience across the country for putting in those very interesting questions that they have. So with this, we will bring this session, another session of Endocrine Talk Show to a close, and over to the organizers.
Thank you, Suvankar sir. Once again, we had a phenomenal session, a fantastic session, which can be witnessed by 1900 live audience, sir. In fact, the count has now crossed 2000, the final count which is coming in. So that's the kind of response we are getting from the consultant physicians across the country, and episode by episode, the number is increasing, sir. So thank you so much for all your guidance, all your encourage of this program, sir. And thanks Parminder Singh, sir. Thank you Rana Bhattasharji, sir. Thanks Godbole, sir. And thanks Dr. Akila Bandarkar, ma'am. Thanks a lot for sparing your valuable time. And I think we'll have lots of scientific initiatives in future too, which would be of immense use to our consultant physicians, because this is one forum which actually drives the latest updates and the latest guidelines, the latest trials, what we witnessed today. In fact, even I was getting a few queries from our DM students. We have a group, dedicated group there, and they were looking forward to this session. They missed the initial part, so they were asking whether the recorded session would be available somewhere. So we'll share the recorded live sessions to these doctors also. And this has been a wonderful session, sir. Thank you so much for sparing your time, sir. And thanks, Dr.
It's
Ankit.
been wonderful to have all these panelists with us, and of
Yes,
course
sir.
your very active team, which drives the sessions month after month. Thank you very much, and
Thank you,
very
sir.
good night to all of you.
Good night.
Thank you,
sir.
Good night.
Good
Thank
night.
you. Thank you.
Bye.
Good night.